So my talk, I don't have a demo like Rota or Rota Pro and atherectomy. My talk is a simple one. This is a much simpler device when you compare to Rota Pro, but I'll just go through how to use it and when to use it. I have some good experience on this therapy, and I found extremely useful in certain situation. Uh, Coming to just laser sign, what is laser is just light amplification by stimulated emission of radiation. These are the FDA currently approved indication for excimer laser coronary angioplasty. First one is very interestingly balloon uncrossable and undilatable lesions. So this is where I feel this therapy has a lot of value, and it has really bailed us out in many of the situations. So this, in fact, I feel it's very important area of therapy. Second is multifocal thrombotic saphenous vein grafts. This also is a very important situation, as you know that especially in our country, a lot of bypasses were done 10 years back, and those patients are coming with acute coronary syndrome and SVG crack, acute MI. So this therapy, I think it's very useful in this situation. Chronic total occlusion, again, once you cross with the wire, when nothing crosses, this is very useful therapy, I feel, and probably you'll also feel like that. I'll show some couple of examples. Moderately calcified lesion, osteal lesion, eccentric lesions, more than 20 millimeters, they're all borderline indication. But instantaneous stenosis, especially when you feel is an under expanded stent, and it's a very good therapy, I feel. So I'll just these are the rare case reports of ALCA use also. When under-expanded, under-deployed stents are there, you can use it to expand the stent well, because this acts outside the stent area. In any calcific plaque, it breaks that plaque, and then you can expand the stent. And also in case of large thrombus burden also it can be used. And the second rare case reports modification of proximal cap of heavily calcified lesion when initial attempts to cross the rotablator wires were unsuccessful. This is also a very useful indication for use of a laser therapy, and we have a couple of examples. I'll show you that. How to use a laser? These are the 5 S of the laser success. Selection of the patient is very important. You should know when to use a laser. The morphology lesions you should know. Size of the catheter, the tighter the lesion, smaller the catheter should be. Settings is very important. You should know what is fluency and what is pulses. And the saline flush is important. Always until you do like a couple of dozens of lasers, you should only use saline. You should not use a contrast or a blood. So you should do flush 1 to 2 cc per second. That's very important. And the speed, you should advance very slowly, so 1 millibit per second, because you'll ablate the lesion when you pass the catheter. And very again important that the size of the catheter should not exceed more than 2/3 of the reference vessel diameter. And when you have more experience with laser, you can use a contrast, so the vapor bubble will be more powerful and more energy is delivered. And some people are doing with the blood, but I still feel, even though I have done 60 cases of laser, I am still not doing any contrast laser or a blood laser. I'm just going saline still. A very important point, you should know what is fluency and rate. Fluency is the energy delivered and directly relation to the size of the vapor vessel. So if you use higher fluency, there's a larger bubble. So higher settings are definitely required in a patient of a calcium or a heavy thrombus burden is there. Second setting you should know is what is rate. The repeated rate of pulse is like jackhammer effect. So if you want to repeatedly hit, increase the rate. If you want to a slower hitting of the rate, you decrease the rate. And this is also, the increasing the rate doesn't increase the size of the vapor bubble. So if you want to have a calcified lesion, so you increase the rate to more. So how will you start doing laser? You start with a low fluency like 25 fluency and 25 rate. And then second pass you can increase the fluency and increase the rate. So you can start with 25 and increase to 45. And if you're more comfortable and the lesion is more calcified, make it 80 also. So that's how first pass should be with lower setting. Second pass increase the fluency and rate, and third pass you can increase both fluency and rate. So these settings you should understand how to increase these settings. I'll just show a couple of examples. This is an 84-year-old male who came to us with end STEMI and cardiogenic shock. He was treated with cardiogenic shock with severe dysfunction. He came. He was advised a bypass surgery. Then patient said he refused for a bypass surgery. He had iron deficiency, anemia, and B12. which were corrected, he came for an angioplasty. So we planned for a rota PCI to LAD first, and then the RCA was CTO, we wanted to do 2 days later. We finished rota angioplasty to RCA, these are the pictures, and this was a regular case, and we stented with this stent, and we took him for angioplasty to RCA here. You can see the contralateral injection, you can see the total occlusion of RCA there, and antegradely it's a very bad tight lesion here. So we use a long sheath for a good power. We used a AL 0.75 for a good backup, and we used a crosshair probe for a support, and we used a fielder XT2 probe and cannulate the crosshair probe, and we crossed with the Gaia 1. So everything were very happy here. You can see the Gaia 1 parked there, and here nothing goes. No micro. My crosshair probe doesn't go. 0.75 millimeters. Alveo balloon doesn't go. And then we put another wire and use an anchor technique, 2x12 anchor balloon. Nothing goes. So we cross the lesion with a Gaia wire, and here we have with a situation where nothing is crossing. So what we'll do? So see again, you can see both in lateral view, you can see my balloon is not crossing. The smallest balloon available and the best balloon available is not crossing. And my anchoring also is very good support, and have AL 0.75. Everything is good, but nothing is crossing. So we have a laser. We use 0.8, 80 fluency and pulse sensitivity up to 80. And this is what I told you, but it did not cross the whole lesion. It makes a space for all the hardware to go. And you can see my laser catheter has not gone all the way the lesion. It made a way that even if you go half of the way, you can deliver all the devices what you want. So this is what we did. And after that, my crosshair probe could cross easily. I put a cyan blue wire, workhorse wire, and we did balloon dilatation with 2 into 12 and 2.75 into 12, and then stented with 48 synergy, and this is a final result, and patient is doing fine 1 year later. So this is one indication I felt definitely, especially in centers where a lot of complex work is done, you need this also to be there in the shelf to bail out in this situation. This is a very nice interesting case where we did a DK crush in a patient with a badly spontaneously dissected coronary artery. He's a 70-year-old male. He underwent a PCS stent in 2008 and he was fine, but now he is having recurrent postprandial angina, which has caused him lose 4 kilos weight loss. This is the left angiogram. The stent is fine, and these are 2 pictures. You can see the stent is fine. If you see the right, you can see this is a bad spontaneous dissection all the way from the right proximal RCA to the distal RCA. There's an angiogram, and we counsel the family that we can fix it with a DK crush. And we thought we might have difficulty in crossing the lesion here, because it's a badly dissected artery. You can go into false limb and you can close the arteries. But we wanted to be very sure that we'll park our wires in both the branches and start doing it. So we started doing it, and this is our first wire. We could cross easily into the PLVW, the bigger branch, and other branch we had a problem. We were stuck here, and we took a microcatheter support, crosshair probe, and we can cross the second lesion. So it means the first wire passed the channel. It is not allowing another wire to pass or any hardware to pass through it. So we thought we'll use a smaller balloon to dilate. Nothing crosses. Then we took a guide extension support, so that because it was a right Judkins catheter, but it doesn't go. 1 millimeter, 1.5 millimeter, the wire is not going, so nothing goes. So here we had again Elka catheter handy, 0.9 millimeters. We used a fluency of 80 and a rate of 80, and for 1.27 minutes, and that made the way. And then we could park our, we could dilate the wire, dilate the lesion. Then we could park the second wire in the second branch, and then we pre-dilate the lesion, and then we did a kissing balloon. There was small extra extravasation of the contrast, which we expected probably because it's a spontaneously dissected artery and we use a laser there. And we used a Ultimaster 2.75 into 28 millimeter stand. We did all the double kiss and double cross and DK crush, the regular, all the steps were followed. And we implanted 3.5, 48, 3.5, 48 Giants expedition. And then this is a final result with the case, and this is a final angio. So just to start with this case, we never thought that we'll use a laser here. We just spontaneously dissected. Our challenge was main to get the first wire. It went in easily, we were very happy, but the second wire we were not able to cross because the lumen is so much. So we used laser here and helped us. So these two situations where I said uncrossable lesion, undilatable lesion, this therapy really works for us, and we're happy with it. A second situation I was very happy with whatever little experience I have is a SVG thrombotic lesion, acute MI situation, what you do. This is a patient we operated in our hospital, our team, only 2009. We had Lima to LAD, SVG Day-1 and OM1 and RCA in 2009. He was admitted in February 2023, another hospital with cardiac shock, recurrent angina, LVF, and then he was shifted to our hospital with recurrent angina and LVF. So we did they did an angiogram, but that was not very good. So we did a re-CT angiogram, and we planned for a SVG, PCA to SVG to OM and diagonal. And if you can see this SVG angiogram, you can see it's very hugely thrombotic burden there. And this is SVG angiogram in other view also. You can see I am crossing with the wire. And we use a ELCA catheter here, 0.9 millimeters ELCA catheter, SVG to OM, and you use a fluency of 60 and repetitive rate of 60, and we put a stent 4x38 onyx stent, and we used a filter here, which I generally don't use, but a lot of people don't believe it. I don't feel much role of filter even acute situation. And this is a final result, and this is TIMI 3 flow. And then after this we did SVG to diagonal on the same setting. So it was both the lesion we wanted to finish. We didn't want Vajan to come back because he had recurrent angina, and this is also pretty bad. And here we just use ELCA laser, SVG to diagonal, and we didn't use a filter. We just wanted to show that even if you don't filter, somehow this is not a randomized trial, but and pre-dilate 2 into 15 millimeters, and we used 2 stents, and this is a final result with a good flow in the diagonal, and this is a final result. So contraindications, yes, there are certain contraindications. Acute angulation, better don't use it because this can cause perforation. Coronary dissections, don't use it. Unprotected left main, don't use it. And if you have long subintimal course in a chronic total occlusion, I think you should not use this therapy. And we can have problems. I had one coronary perforation because it was a distal PLVW branch, huge branch. It was acutely angulated, acute MI, huge thrombus burden. I made a mistake there. So even though good experience, still mistakes can happen, and patient had a perforation. Take home message, laser atherectomy is a valuable tool for treating complex and resistant coronary lesions. I feel definitely it's one of the therapies you should have in your lab if you start doing more complex procedures, especially uncrossable lesion. Efficacy and safety are well established when patient applied appropriately, and you can get good results. We need definitely more data to routine use of ELCA in patient with instant restenosis and heavy thrombus burden. We don't have much data still. Make sure that you follow all the 5 S's of ELCA. When to use this lesion, what is the setting, saline flush, slow sizing of the catheter, slow advancement of the catheter. These are very, very important things when you use laser therapy. Thank you very much.